Our next presentation is Sernova, and I'd like to welcome Jonathan Rigby, CEO, to the stage.
Hey, good morning, everybody. Welcome to hot and toasty Phoenix, Arizona. I know you have choices of presentations to go to and listen, so thank you for coming to listen mine. As mentioned, my name is Jonathan Rigby. I am the CEO of Sernova. And I want to talk to you today about something that we are incredibly passionate about, and that is our mission to give patients their lives back. So please look at this disclaimer regarding forward-looking statements. And I'm going to give you Sernova in a little nutshell. So we are based in London, Ontario, where we have our offices and our laboratories. We also have a small office in Boston. We are focused on a regenerative medicine approach that utilizes our proprietary cell pouch technology, and our lead program is for the treatment of patients with type 1 diabetes. It's a phase 1/2 study. Dr. Piotr Witkowski is our PI at the University of Chicago on this program, and he recently presented some new data at the EASD conference in Madrid. And with respect to our ongoing T1D program, Dr. Witkowski said he's never seen data like this, and he believes that Sernova are way ahead of the field across the world. He presented data from a patient using our cell pouch with human donor islets that was insulin independent for over 4 years. Upon explantation of these cell pouches, histology showed that we have abundant islet cell survival and function after more than 5 years. And currently, the study is an adaptive design. We've completed cohort A. We are ongoing with cohort B, and cohort C will initiate in the first part of next year. We're clearly very excited for that to happen. And we're also partnered with Evotec, who are working with us, joined at the hip, to also give patients their lives back with their iPSC cells, also utilizing our cell pouch technology to treat patients with type 1 diabetes. We're also looking to get into the clinic early next year in hypothyroidism, and we shall be submitting our IND imminently. And we have some very exciting preclinical data looking at hemophilia A. So anybody in the audience know somebody with type 1 diabetes? A show of hands? Okay, a lot. So you're going to concur with me on this slide. It's a slide that I love, and it's a slide that I hate. Why do I love it? Because I also am a type 1 diabetic and have been most of my life. So I live this thing and I work this thing 7 days a week, every day of the year. The reason I don't like this slide is because, we have to be honest with ourselves. That with respect to satisfying the needs in type 1 diabetes, we haven't done it. And in fact, we are nowhere near being there yet. We've got a big gap to close, and we will do it. So the reality of long-term uncontrolled type 1 diabetes is that these patients still get heart disease. You still get diabetic nephropathy. People have eye problems. There's a gigantic Costco-sized TV on the floor here with my slides, and I can barely read my own writing because of the detriment to my eyesight over time, and it's getting worse. People get foot problems, which result in amputations often. But a scary statistic at the bottom of the slide, 1 in 10 patients with T1D will die of severe hypoglycemia. I took my 10-year-old son to a Yankees game recently. We had a great time. We stayed overnight in a hotel. 7 o'clock in the morning, he was pouring Coca-Cola in my mouth and giving me glucose tablets because I was having a severe hypoglycemic attack. If it wasn't for him, maybe I wouldn't be here presenting to you guys today. So how do we currently treat diabetes? We've come a long, long way from where we used to be when I was diagnosed several decades ago. And right now, we have needles and syringes where we can inject human recombinant insulin. We have pre-filled pens. We have an insulin pump. I use an insulin pump, which communicates with a continuous glucose monitor to control, to the best extent possible, my diabetes. However, controlling diabetes is not just about insulin. and we're only giving patients insulin. Insulin lowers your blood glucose, then we have glucagon, which raises your blood glucose, and then we have somatostatin, which controls insulin levels and glucose levels in a non-diabetic patient. So we're about a third of the way there with lots of room to go. And in fact, on the bottom of this slide, you can see a printout from my Dexcom continuous glucose meter. I printed this out last Thursday before I submitted this presentation. And that's a typical day for me. So you'll see that I'll have a meal and my blood sugar will spike, I'll give myself insulin, and about an hour and a half later it will come flying down. And then for no apparent reason it will go flying up again. So I'll give myself more insulin and it starts to come down in a rate that's too rapid. And then I get into the normal zone and my sugar goes up a little bit, and then I'm coming down into a hypoglycemic event. So this is not unusual. This is a curve from every day in my life, and I'm a well-controlled diabetic. So we do have lots to do here. So at Sernova, we are developing what we believe has the potential to be a functional cure for type 1 diabetes. On the left, you see our proprietary implantable porous system. We call it the cell pouch. And what you can see, there are 8 chambers in the cell pouch, which upon manufacture contain these PTFE rods, which maintain a cylindrical space within the cell pouch. The surgeon will then implant the cell pouch above the muscle in your abdomen, but beneath your skin, and then vascularization will start. So the porous pouch will become vascularized with blood vessels. And after about 4 weeks, the physician will go back in. He will then remove the PTFE rods and impregnate the cell pouch, in this case with human donor islets, in the future iPSC islets. Then quite miraculous, on the right-hand side, you can see that over time, the cell pouch actually develops into a biosimulated organ. And if you look closely at the image, you can see that there is no fibrosis and there is full structural integrity maintained. In fact, in the bottom left, you can still see the actual channels. But we've explanted these after 5 years. We've proven clinical safety and efficacy. And even after 5 years, we're showing abundant production of glucagon, insulin, and somatostatin from these islet cells. So the first part of our study is an adaptive trial. 6 out of 6 patients received 2 islet transplants and a portal vein top-up of islets, but all of the patients achieved insulin independence, with durations ranging from 9 minutes from a patient who was still in the study and ongoing to more than 4 years. Patient number 1, as mentioned, was insulin independent for over 4 years, with functioning islets after 5 years. And all patients, importantly, achieved A1C levels in the non-diabetic range, i.e. less than 6.5%. So in this study, we were able to determine the optimal islet concentration per chamber and the density of islets per chamber in the cell pouch. We did see donor-specific antibodies in 3 of the patients, which gave us some time to adjust their immune suppression to prevent islet rejection. I mentioned here that all the patients became normal A1C levels. Some of them started with normal A1C levels, but that was maintained without the use of exogenous insulin. The blue is before the implantation, the orange is after. And you can see a couple of patients that had really, really out of control, very high A1C levels. And over time, with the cell pouch implantation, those came down to the non-diabetic range. Many clinical trials have shown if you reduce the A1C level by 1%, that correlates to a 14% reduction in the risk of myocardial infarction. So this is important. In the second adaptive cohort, our goal here was to develop a modified immunosuppression regime that was better tolerated than one in the first cohort. 7 of 10 patients have been transplanted. 1 of the 7 reached insulin independence, and 5 of the patients experienced graft rejection due to a suboptimal immunosuppressive regime. So then we modified that and determined a novel optimized immune suppression regime for the remaining 4 out of the 10 patients. 1 was recently transplanted and is doing very well and is ongoing, and 3 patients remain to be enrolled in this cohort. So if you look at the pink images across the middle of this slide, again, this is a cell pouch explanted after 5 years post-implantation. And you can see that there's rich vascularization of abundant insulin-producing cells and no evidence of detrimental fibrotic tissue around the pouch. The little circles, 1, 2, 3 to 8, they demonstrate that functional integrity. Importantly, in the immunofluorescence stains, we see that we're producing insulin after 5 years. We can see the von Willebrand factor, which is an indication of the live and thriving blood vessels, and also we see glucagon and somatostatin. So this really drives me and the rest of the people at Sernova to get up every day and drive towards what we believe one day will be a functional cure for type 1 diabetes. I mentioned on my first slide that we have an ongoing partnership with Evotec, and they are also working with us on a daily basis to give patients their lives back. And Evotec have been working hard with Sernova to develop iPSC-derived islet-like cluster cells. You can see some of those beautiful little islet-like clusters in the image on the top left of this slide. And so Evotec have developed a scalable GMP-compatible process for the ILC manufacturing production from a GMP PSC line, iPSC line. On the image to the right, you can see that also these cells are uniform. They're in an unlimited quantity, but we are producing insulin, we are producing glucagon, and we're producing somatostatin to regulate them. On the right-hand side, we have many slides like this from preclinical work where we take a diabetic mouse model and we prevent their pancreas from producing insulin. So you can see on the left of the graph, we have significantly high blood glucose levels in these animals. They are then implanted with the Evotec iPSC cells, and we've also done studies using our cell pouch to put these iPSC cells into these mice. And pretty quickly, the glucose starts to drop, and it quickly gets into the normal, controlled diabetic range. But look at the consistency of that control and the very, very low variability. So again, we are enthused about bridging from our human donor islet program to the Evotec iPSC program in the non-too-distant future. I just want to leave you with this one slide. Hopefully, for those of you who put your hands up in the air because you know people with T1D, it'll give you some hope. And this is from the patient that was independent of insulin for over 4 years. And she says, after having T1D for over 47 years, I can easily state how absolutely wonderful life is to be free of always thinking of how to manage my diabetes. My only wish is that it could have been done sooner. So again, thank you and welcome to Hot and Toasty Phoenix, and I'd be happy to chat with anybody after the presentation. Thank you very much.